السلام عليكم ورحمة الله. مستشفى السعودي الألماني بالرياض أرحب بالحضور أو السبيكر والدكتور وليد العياضي CMO and Head of Department Cardiothoracic Surgery Consultant. تفضل سعادتك تقديم كلمة افتتاح المؤتمر.
السلام عليكم جميعا. يعطيك العافية دكتور لطفي. It gives me a great pleasure to greet our respected speakers, guests, colleagues, and attendees. A pleasant good afternoon to welcome to the first annual SGH Riyadh OB Gyne webinar. This event will surely provide the participants up-to-date information covering the specialty of OB Gyne. Our world is constantly changing, therefore all medical practitioners must always be attuned to the changing in times in order for them to be at par with other medical practitioners in the world. Continuous professional medical education is needed and is a basic requirement in providing safe, quality care to the patients. It also provides better coordination with other medical specialties in giving the correct diagnosis and patient management that will surely result in superior medical outcome and patient satisfaction. At this point, let me take this opportunity to commend the organizing committee and all involved in preparation and making this event a success. It's an honor for me to be here with all of you, and hopefully we continue to strive to improve our healthcare service through conducting medical activities like this. My great appreciation also goes to the speakers for wholeheartedly sharing their time and knowledge in this event. Thank you very much, and I hope to see you again in the future. Have a fruitful day ahead, inshallah.
Thank you very much, Dr. Walid. The scientific program, the first session, we start lectures from Dr. Zainab Al-Talal. Zainab Al-Talal is an eminent oncologist, gynecologist, and head of the department, the Annual SGH. The topic will be when to refer your patient to gynecology oncologist. Okay, Dr. Zainab, welcome to start your lecture.
Hello, مساء الخير. First of all, I want to thank the organizing committee, Dr. Walid, Dr. Lutfi, especially Tamer, for the effort they put with us, and all the effort they put to do this meeting. I'm going to share my screen with you guys. Can you see my screen?
Yeah.
Huh? Sorry?
Still no.
Still no.
Okay.
Slide not appear on the.
Okay. Do you see my screen now?
Yes.
Yeah, start.
Great. Today's my topic is very light, just giving some enlightenment and some light on the cases that we need to refer to our gyne oncology. The gyne oncology subspecialty is there to help everybody, where we have a great relationship with our gyne colleagues and our obstetricians also. There is a lot of demand on the specialty lately because of the increased number of akrita and perikrita, increased number of endometriosis cases, and with the great effort of our gynecologists, they started picking up abnormality and cancers very early and referring them very soon to gynecology oncology. So I'll start my presentation with this slide. This is a 2020 statistics for our new cases in females for all ages. As you can see, that breast still our first cancer is 1 in 4 almost. Then colorectum, lung, and then the surprising part is cervical cancer is becoming now the almost after lung cancer. We were expecting as an oncologist that cervical cancer will decrease in incidence, but this, this is a worldwide statistics, and most of the developing country, the cervical cancer is still one of the common cancers diagnosed. Cervical cancer followed by uterine cancer, and then it will be followed by ovarian and then vulvar cancer. So as we all know, it's an important prognostic factor that our patient with suspicious masses or suspicion for cancer to be operated by a gynecologist oncologist. This will improve patient outcome, patient prognosis, patient survival rate. The gynecology oncology can treat this patient with surgery and then refer her to medical oncology in a timely manner. Surgical management is a cornerstone for all oncology cases, since surgery can impact severely the patient survival and the patient quality of life. It was reported that referrals from general obstetrician and gynecology, it carries around up to 80% sensitivity and accuracy referring patient with a malignant disease to an oncologist. We should refer patients who are confirmed to have malignancy or patients who are suspicious of malignancy. Our gyne cancer, we have the common fours. Most commonly, we always face in the clinic abnormal or suspicious ovarian mass. Can be ovarian, peritoneal, fallopian disease. They all carry the same symptoms and findings usually in ultrasound. The second malignancy, which is usually picked up easily by the general gynecology, is the uterine malignancy, especially endometrium. Endometrial malignancy is one of the very common malignancy diagnosed due to the early symptoms that the patient exhibit. And also one of the uterine malignancy, which is rare, is uterine sarcomas. Usually those patients, they come with the suspicious uterine fibroid, and then usually the gynecologist will refer her to an oncologist. Other uterine malignancy, which is the gestational trophoblastic neoplasia, which is now we are diagnosing gestational trophoblastic neoplasia earlier in the early course of the disease and acting early, so the patient, they don't usually present with the metastasis or persistent disease. The third common cancer that's picked up by gynecologists is cervical cancer, but usually it's picked up in a late stage of the disease. Lastly is the vulvar and vaginal cancer, which is very rare. It's usually the fifth most common cancer, and patients usually they are at the older age group than the other cancers. So we'll start with the uterine malignancy. As I said, uterine malignancy can be an endometrium, sarcoma, can be GTN, but the most common is the endometrium. It's one of our most common gyne cancer diagnosis. The lifetime risk is 2 to 3%. Mean age, usually it occurs in older age group, except for a subset of endometrial cancer that occurs in a younger age group. Usually it affects the postmenopausal women. It affects almost 20 to 25 perimenopausal women, and almost 5% in a woman who are younger than 40 years of age. The risk factors and relative risk, which is unopposed estrogen, that increases the risk of endometrial cancer greatly. Obesity, as all other cancer, obesity is increasing. It increases the risk of cancer for any obese patient. Diabetes, PCOS, late menopause, nulliparity, tamoxifen use, especially in the a subset of patient who has breast cancer and taking tamoxifen as a post-surgery and post-chemo. Then a patient who have genetic disease, like the HNPCC, they have very high risk, almost 40% risk of developing an endometrial cancer in their course of disease. So when to refer uterine malignancy to an oncologist? When you have an endometrial biopsy with the proven cancer or hyperplasia, when you have a suspicious uterine mass, especially when you are following up a patient for a long time period, and then you find out that her fibroid is increasing rapidly in size, there is some abnormal degeneration picked up by MRI, there is an abnormal fluid in the pelvis. These are the risk, the suspicious mass that we should refer to an oncologist. And then if you have patients who are diagnosed already with the gestational trophoblastic disease, but have an increasing titer or persistent plateauing titer, or their initial diagnosis was choriocarcinoma. Those patients are usually taken care of by the gyne oncologist, along with the medical oncology. Some of those patients, they will need surgery to decrease their level dramatically, especially in the older age group. Ovarian cancer, the lifetime risk is less than the endometrium, which is 1.7 to 2 lifetime risk. What I highlighted in red in my presentation, which is that ovarian cancer affects females of all ages. We have many patients who are very young, diagnosed with epithelial cancer, not even a germ cell or sex cord. So that's why we need to suspect ovarian cancer in any female at any age when she presents with suspicious mass by ultrasound. The types of ovarian cancer, most of those cancers are epithelial, followed by germ cell tumors, and then sex cord and stromal. What's very known about sex cord, they are usually hormone producing. So those patients, they will come with abnormal bleeding, precocious puberty, stuff like that. But the most common type of ovarian cancer is an epithelial cancer. Okay, so when to refer a patient to an oncologist as a case of suspicious mass or ovarian cancer? If the patient has a genetic disorder like BRCA1, BRCA2, HNPCC, the BRCA1 and BRCA2 usually are diagnosed, and then we call them the index cases. They are the primary cases who are diagnosed with cancer and then tested for genetic disorder. You don't have to test your patient for BRCA1 or 2, because if the index case is tested, we don't need to test the rest of the family. Also risk a patient with HNPCC, family history of that disease will increase your cancer from almost 15% in those patients for ovarian cancer. Of course, suspicious mass, when you do an ultrasound, a simple ultrasound can show you abnormal papillary growth, the size of the mass, the complexity of the mass, association with ascites, omental deposits. All of these findings by ultrasound or by CT, those cases, they should be referred to an oncologist. Another thing we are facing quite frequently in our practice, a patient with endometriosis. We usually do CA-125 as a baseline for all our endometriosis patients. And then we do like a frequent follow-up CA-125 just to check the activity of the disease. What's important in endometriosis patients that we check the trend of the CA-125. Any case of endometriosis, you should never discharge them from your clinic. Those cases, they have 2 to 4% chance of developing an ovarian cancer, endometrioid, or epithelial cancer, or clear cell carcinoma in their ovary during the course of disease. So CA-125, we should repeat for our patient regularly, and we should not discharge our endometriosis patient from our clinic. Cervical cancer. Cervical cancer, unfortunately, is one of the cancers that affect primarily young patients. The mean age is 49 years of age. Those patients usually they present with abnormal postcoital bleeding, and usually we pick up those cases in Saudi late in the disease. We are most of the time they are inoperable. They need chemo radiotherapy. Those patients usually they are not ignored. I would say that they are not given a full attention in the clinic when they complain of persistent postcoital bleeding, persistent abnormal vaginal discharge, even if it's not foul smelling, persistent abnormal vaginal discharge, whatever it is, we should check the patient and take a pap smear for her, or do a simple speculum exam. If the cervix looks suspicious, we should refer the patient to colposcopy and to be checked by an oncologist. As I mentioned in the first line, it's a disease of developing countries. In our country, we just started our national program in some areas in the country, but it's not widely spread. But many patients now they're educated and they come and ask about the pap smear regularly. We're also seeing internationally the effect of HPV vaccine, where we were promised that cervical cancer will be a disease of the past, that we will not see any more cases in the coming 10 years. Actually, the developed country, because of the vaccine, the incidence of cervical cancer has decreased tremendously. Even the incidence of peri-invasive disease in the cervix has decreased tremendously from 2005 due to the introduction of HPV vaccine. So as I said, the mean age for cervical cancer, usually they are in young patient at 47 years of age. We have two common types. The common type is squamous carcinoma or adenocarcinoma. The presentation is the same. The causative factor, usually almost 97% of the cervical cancer is HPV related. Rarely we can have cancer which is not HPV related, like a small cell or neuroendocrine cervical cancer, which is very rare. So what are the risk factors? Early onset of intercourse, patient with multiple partner or having a high risk partner, smoking, and immunosuppression. When we introduce the cervical HPV vaccine in 2005, it was introduced for cases for young girls and boys who did not start their sexual life yet as a primary prevention, and the prevention in those cases is up to 100%. Now we are starting for the past almost, I would say, 7 years. We started the secondary prevention for patients who are already infected with HPV, who changed recently the partner or had abnormal smears. We started secondary prevention by offering those patients the Gardasil vaccine or non-valent HPV vaccine. Studies have showed that the risk of recurrence of resistant disease has decreased to up to 40 and 50%, even for the benign changes, which is warts, vulvar warts or vaginal warts. They have decreased up to 40 and 50% in those cases, which is a pretty good percentage as a secondary prevention. So I want to refer a patient with persistent postcoital bleeding, excessive vaginal discharge, suspicious cervix on examination, or abnormal pap smear. We know we're picking up, because of the pap smear, we're picking up a lot of patients with abnormal cells like L cell or H cell. Those cases, if we treat them early and give them the vaccine, their risk of developing cervical cancer will decrease because we're going to decrease their persistent disease, which improve the patient chances of having, delaying her cancer disease as much. Those patients, they will always be under our follow-up in colposcopy clinic. The last cancer we're going to talk about is the vulvar cancer. Vulvar cancer is our fourth most common gynecological cancer. It's almost 5% of all malignancy in female genital tract. Usually those patients are older age group, usually with a lot of more comorbidities like diabetic, obesity, hypertension, bedridden. They are usually complaining of long-lasting pruritus, or less likely they will come with vulvar bleeding, bleeding ulcer, chronic ulcer, or pain. Sometimes they come with dysuria if the disease is central in the vulva. When to refer those patients, we usually, the gynecologist refer to a gyne oncologist if an old lady coming with a chronic bleeding vulvar ulcer, pruritus not responding to treatment, known cases of VIN, which are valvular intraepithelial neoplasia, or patient with lichen sclerosis. I want you to pay a lot of attention with patients with lichen sclerosis. We know that lichen sclerosis is not a risk factor for cancer, but it's a predisposing risk factor because of the cycle of itching, injury, skill changes, cell changes. This cycle can predispose the patient to have a vulvar cancer. So usually lichen sclerosis patients are followed up by gyne oncology, and they will have a regular colposcopy checkup. And this slide, I would like to show you the four main causes or risk factor for gynecological cancer. First of all, the family history, as we mentioned, BRCA1 or 2, HNBCC, even any patient with personal history of cancer, breast or any colorectal cancer, she is at risk of developing a secondary cancer. A patient who has a family history, first degree with ovarian cancer, even if they don't have a genetic disease, this patient, she has 2 to 3 times risk of having an ovarian cancer. So those patients usually keep them in our clinic, and we follow up those patients regularly with CA125, transvaginal ultrasound, just to pick up any cancer changes early in the course. The other risk factor is obesity. As we say, that obesity is a mother of all diseases. When those patients, usually they have a chronic inflammation in their body. Chronic inflammation predispose the patient for abnormal cell repair that predispose the patient to a cancer risk. Age, we know that cancer is a disease of an older age. So whenever the patient is postmenopausal, usually they are more predisposed to a cancer than the perimenopausal age. HPV is related to cervical cancer, vulvar cancer, and vaginal cancer. So any patient who are known to have a high risk HPV infection should be always referred to an oncologist for regular colposcopy checkup. I just want to pay your attention. I just want to draw your attention to other situation that you can refer to a gyne oncologist. Cases of severe endometriosis. As I said, we're seeing those cases frequently in our clinic. Those cases usually they present with severe pelvic pain. They want a pelvic clearance, or they have a hydronephrosis secondary to endometriosis. They present saying that they were diagnosed with a frozen pelvis by another gynecologist. Usually those cases will be better dealt with the gynecologist due to our vast knowledge of the pelvic anatomy, the retroperitoneal spaces. The dissection in those cases can be quite difficult. Patient also with cervical fibroid, usually those patients, they are high risk of bleeding, and in the presence of a gynecologist that we can do decrease the risk of bleeding by doing uterine arterial ligation or do an internal iliac arterial ligation, but the patient we can save her uterus by doing that. Last but not least, placenta accreta and pericreta. Gynecologists are a fundamental or a very important member in the team of placenta accreta and pericreta because of our knowledge of the pelvic anatomy and the blood supply to the pelvis. This will take me to the end of my presentation. Thank you all.
Thank you very much, Dr. Zainab, for this comprehensive lectures. And we ask any questions. The question that what is the indication for pelvic lymphadenectomy in endometrial cancer?
Actually, any patient with endometrial cancer, we should do a pelvic lymphadenectomy for her. This is part of our staging for this patient. Patients who are known to have endometrial cancer and did the surgery without pelvic lymphadenectomy, it means this is an incomplete staging. This patient should have either a laparoscopic lymphadenectomy after the hysterectomy, or they will be treated with chemotherapy or radiation therapy, depending on the risk factors.
Another question, patient who is asked us in pap smear, what's the next step?
As you know, personally, I treat patients with ASCAS in our country as a patient with high risk because we don't have a screening program. So we don't know what's the background of this patient. I do HPV testing for those patients, or I take them to colposcopy right away because we don't know what's the background for this patient.
Another question, if a female with human papillomavirus infection, did you advise to give vaccination of human papillomavirus again, despite she's infected, and her husband also?
Of course, I would. I don't know about the husband, but I know about the lady. After we identify her HPV status, like what kind of HPV virus she has, depending on that, we're either going to offer her a Gardasil, which is a quadrivalent vaccine, or we advise for non-valent. Now we usually encourage our patients to take the non-valent, but unfortunately in Saudi we don't have it yet. It's on the way, but we don't have the Saudi FDA license for this vaccine yet. But we give vaccination for all our patients as a secondary prevention after doing the HPV typing for her.
Okay, thank you very much, and see you inshallah next meeting. Good
Inshallah.
luck.
Thank you.
Next topic in the session is endometriosis by Dr. Mohammed Lotfi.
دكتورة زينب ممكن حضرتك تعملي ستوب شيرنج؟
Dr. Zainab, please
Sorry?
stop sharing. Please make stop sharing.
Okay. All right. Sorry. Done.
Okay, so we start about endometriosis. Introduction, symptoms, signs, how to diagnose, and the treatment. Endometriosis means functioning endometrial cells are implanted in the pelvis outside the uterine cavity. The symptoms depend on location of the implant. Endometriosis is usually confined to the peritoneal surfaces of the pelvic organs, like the ovaries, broad ligament, cervical-disc, and uterosacral ligaments. Less common sites include the fallopian tubes, serosal surfaces of small and large bowel, ureters, bladder, vagina, cervix, surgical scars, and rarely the pleura and pericardium. Bleeding from peritoneal implants is thought to initiate sterile inflammation, hyperindemposition, adhesion formation, and eventually scarring, which distorts surface of organ, leading to pain and distorted pelvic anatomy. The incidence is reported to be 6 to 10% in all women, 25 to 50% in infertile women, 70 to 80% in women with chronic pelvic pain. The average age at the diagnosis is 27 years, but also among adolescents. The etiology and pathophysiology. The etiology is the theories. Most widely accepted theory for the pathophysiology of endometriosis is that the endometrial cells are transported from the uterine cavity during menstruation and subsequently become implanted at the ectopic sites. Retrograde flow of the menstrual tissue to the through the fallopian tube is common and could transport endometrial cells intra-abdominally through lymphatic circulatory system and transport the endometrial cells to distant sites, pleura and pleural cavity, like pleural cavity. Another hypothesis is ceromic metaplasia. Ceromic epithelia is transformed into endometrial-like glands. Microscopically, endometriotic implant consists of glands and stroma, histologically indicate an intrauterine endometrium. These tissue contain estrogen and progesterone receptors and thus usually grow, differentiate, and bleed in response to the changes in the hormonal level during the menstrual cycle. Also, some endometriotic implants produces estrogen and prostaglandins. Implants may become self-sustained or regress, as many occur during pregnancy, probably because progesterone levels are high. Ultimately, the implants cause inflammation and increase the number of activated macrophages and production of pro-inflammatory cytokines. The increased incidence in the first degree relatives of women with endometriosis and in large twin studies suggests that it is hereditary factors. In patients with severe endometriosis and distorted pelvic anatomy, the infertility rate is high, possibly because of the distorted anatomy and inflammatory interface. This is a mechanism of ovum pickup, oocyte fertilization, and tubal transport, fertilization and tubal transport. All this affected due to inflammatory reaction and due to distortion of the tube. Some patients with minimal endometriosis and normal pelvic anatomy are also infertile. Why? This unclear, but maybe increased incidence of luteinized and ruptured ovarian follicle syndrome, the trapped oocytes, increased peritoneal prostaglandin production, or peritoneal macrophage activities that may affect fertilization, sperm, or oocyte function, non-receptive endometrium because of luteal phase dysfunction and other abnormalities. Some risk factors for endometriosis, including the family history of first-degree relative with endometriosis, the delayed childbearing or nulliparity, early menarche, late menopause, shortened menstrual cycles, less than 27 days, with menses that are, and heavy prolonged menstruation more than 8 days. Mullerian defect, that is obstructive of the uterine outflow tract obstruction. exposure to diacetylcholesterol in utero. Some protective factors, including multiple births, prolonged lactation, late menarche, long-term use of low-dose oral contraceptives, continuous or cyclic, and regular exercise, especially if begun before age 15, if done for more than 4 hours a week or both. The symptoms and signs of endometriosis. There is a classic triad which we will not forget. Pain, dysmenorrhea, dyspareunia, and infertility. The dysmenorrhea, cyclic midline pelvic pain, specifically pain preceding, during, and during sexual intercourse. Dyspareunia is typical and can be progressive and chronic, lasting more than 6 months. Adnexal masses and infertility are also typical. Interstitial cystitis with suprapubic or pelvic pain. Urinary frequency and urge incontinence is common. Intermenstrual bleeding is possible. Some women with extensive endometriosis are asymptomatic. Some with minimal disease have severe pain. Dysmenorrhea is an important diagnostic clue, particularly if it begins after several years of relatively pain-free menses. Symptoms often lessen or resolve during pregnancy. Endometriosis tend to become inactive after menopause because estrogen and progesterone level decreases. The ovaries, there is formation of an endometrioma, 2 to 10 centimeters cystic mass localized to an ovary, which occasionally rupture or leak, causing acute abdominal pain and peritoneal signs. Adnexal structure, formation of adnexal adhesions, resulting in pain mass or pain. Bladder, dysuria, hematuria, suprapubic pain, particularly during urination, urinary frequency, urge incontinence, or combination. Large intestine, pain during defecation, abdominal bloating, diarrhea, constipation, or rectal bleeding during menses. Extrapelvic structures like vague abdominal pain sometimes. The pelvic examination may be normal, or finding may include retroverted and fixed uterus, enlarged or tender ovaries, fixed ovarian masses, thickened recto-vaginal septum and nodularity, duration of the cul-de-sac, nodules on the uterosacral ligaments, and or adnexal masses. Rarely, lesions can be seen on the vulva, cervix, or in the vagina, umbilicus, or surgical sites. How to diagnose? Direct visualization, usually during pelvic laparoscopy, sometimes biopsy. Diagnosis of endometriosis is suspected based on typical symptoms. Misdiagnosis as pelvic inflammatory disease, that is differential diagnosis, urinary tract infections, or irritable bowel syndrome is common. Negative cervical and or uterine culture suggests the probability of endometriosis. The diagnosis must be confirmed by direct visualization, usually via pelvic laparoscopy, but sometimes via laparotomy, vaginal examination, sigmoidoscopy, or cystoscopy. Biopsy is not required, but result can confirm the diagnosis. Macroscopic appearance during the laparoscopy, you can find clear, red, blue, brown, black, and sizes of implants vary during the menstrual cycle. However, typically early lesions are clear, red, hemorrhagic. As the blood in the lesions oxidizes, they turn purple, then brown, then become bluish. The spots that are more than 5 millimeters and resemble powder burn. Macroscopically, endometrial gland and stroma are usually present. Stromal element in the absence of glandular element indicate rare variant of endometriosis called stromal endometriosis. Imaging tests don't reliably detect endometriosis. However, these tests sometimes show an extent of endometriosis and thus can be used after diagnosis to monitor the disorder and respond to treatment. An ultrasound showing an ovarian cyst consistent with an endometrioma is highly suggestive of the diagnosis. Presence and size of ovarian endometrioma are part of the staging system of endometriosis. Stage 3, small endometrioma. Stage 4, large endometrioma. And the decrease in endometrioma size can show response to treatment because endometrial tissue had the unique MRI signal. MRI is becoming increasingly useful for evaluating patients who may have endometriosis. No laboratory tests contribute to diagnosis of endometriosis, but sometimes we find increase in CA1 to 5. Testing for other inflammatory disorder may be indicated to differential diagnose between any pathology in the urinary tract or bowel and differentiated from endometriosis. Staging endometriosis helps the physician to formulate treatment plan and evaluate the response to therapy. According to American Society for Reproductive Medicine, endometriosis may be classified as stage 1 minimal, 2 mild, 3 moderate, 4 severe, based on number, location, depth of implant, presence of endometrioma, and filmy or dense adhesions. Endometriosis fertility index has been developed to stage endometriosis associated infertility. This system can help predict pregnancy rate after various treatments. Factors used to score the EFI include the woman's age, the number of years has been infertile, history or absence of prior pregnancies, the least function
مفيش صوت يا الصوت قطع السيستم.
Can start now. Sorry for this connection problem. To come to the treatment. The treatment here we can summarize for non-steroidal anti-inflammatory for discomfort, estrogen progestin contraceptives, drug to suppress ovarian functions, conservative surgery like resection or ablation of endometrial tissue with or without drugs, total abdominal hysterectomy with or without bilateral salpingophorectomy if the disease is severe and the patient has completed childbearing. It is not, I mean, here. This one not working. Symptomatic medical treatment begin with analgesics and hormonal contraceptives. Drugs and conservative surgery are used mainly to control symptoms. In most patients, endometriosis recur within 6 months to 1 year after drugs are stopped unless ovarian function is permanently or completely ablated. Endometriosis may also recur after conservative surgery. Conservative surgical treatment of endometriosis is excision or ablation of endometriotic implants and removal of the pelvic adhesions during laparoscopy. Most definite treatment must be individualized based on the patient's age, symptoms, desire to preserve fertility, and on the extent of the disorder. Total abdominal hysterectomy with or without bilateral salpingophorectomy is considered definitive treatment of endometriosis. It helps prevent complications and modify the course of the disease as well as relieving symptoms. However, endometriosis can recur. Drug therapy that suppresses the ovarian function inhibit the growth and activity of the endometric implant. The following are commonly used: continuous combination estrogen progesterone contraceptive. The following drugs are usually used only when women can take combination oral contraceptive pills or when the treatment with combination oral contraceptive pills is not effective, like progestin, gonadotropin releasing hormone agonist, gonadotropin releasing hormone antagonist, and danazol. Gonadotropin releasing hormone agonist initially increased hypothalamic gonadotropin releasing hormone secretion, but continued use
الفويس is interrupted, Dr. Lotfi.
sorry.
الصوت راح. Now it's okay. We could not hear you before.
Sorry for this internet connection is unstable. So the gonadotropin releasing hormone agonist, this used to temporarily decrease the pituitary releasing of follicular stimulating hormone for FSH, resulting in decrease in estrogen by the ovaries. However, treatment is limited to 6 months because long-term use may result in bone loss. If treatment more than 4 to 6 months, progestin or biphosphonate may be used concurrently to minimize bone loss. If endometriosis recur, women may need to be treated again. Gonadotropin hormone releasing antagonist like Lagolex directly decrease the gonadotropin releasing hormone secretion, thus suppress pituitary release of FSH and estrogen production by the ovaries. It is available in 2 different doses. Higher dose is available to treat dyspareunia, as well as other symptoms of endometriosis. Long-term use may result in bone loss. If treatment lasts more than 6 months, progestin may be used concurrently as backup therapy to minimize bone loss. Gonadotropin releasing hormone antagonist Lagolex combined with estradiol 1 mg and norethindrone 0.5 mg is undergoing clinical trial to use as primary treatment for endometriosis. This combination minimizes hot flashes, bone loss. Use is limited to 24 months because possible continued bone loss may be irreversible. Danazol, this and all the medication, it is synthetic androgen and anti-gonadotropin, inhibit ovulation. However, its androgenic adverse effect limit its use. Cyclic or continuous combination of oral contraceptives given after danazol or gonadotropin releasing hormone agonist may slow the disease progression and are warranted for women who wish to delay childbearing. Drug treatment doesn't change fertility rate in women with minimal or mild endometriosis. Surgery. Most women with moderate to severe endometriosis are treated most effective by ablating or excising as many implants as possible, while restoring pelvic anatomy and preserving fertility as much as possible. Superficial endometriotic implants can be ablated. Deep implants can be excised. A specific indication for laparoscopic surgery include moderate or severe pelvic pain that does not respond to drugs, significant pelvic adhesions, desire to maintain fertility, presence of endometrioma, fallopian tube obstruction, pain during intercourse, dyspareunia. Lesions are usually removed via laparoscope. Peritoneal or ovarian lesions can sometimes be electrocauterized, excised, or uncommonly vaporized with laser. Endometrioma should be removed because removal prevents recurrence more effective than drainage. After this treatment, fertility rates are inversely proportionate to severity of endometriosis. If resection is incomplete, gonadotropin-releasing hormone agonist or antagonist are sometimes given during the perioperative period. But whether this tactic increases fertility rate is unclear. Laparoscopic resection of the uterosacral ligament with electrocautery or laser may reduce midline pelvic pain. Rectovaginal endometriosis, the most severe form of the disease, can be treated with the usual treatment of endometriosis. However, colon resection or surgery may be required to prevent obstruction of the colon. Hysterectomy with or without ovarian conservation should usually be with or without ovarian should usually be reserved for patients who have moderate or severe pelvic pain, who have completed childbearing, and who prefer definite procedure. Hysterectomy is done to remove adhesions or implants that adhere to the uterus and the cul-de-sac. If a woman less than 50 require hysterectomy with bilateral salpingoprectomy, supplemental estrogen should be considered to prevent menopausal symptoms. Also, concomitant continuous progestin therapy like medroxyprogesterone acetate 2.5 milligram orally once a day is often recommended because if estrogen is given alone, residual tissue may grow, resulting in recurrence. If symptoms persist after salpingoprectomy in women more than 50 years old, continuous progestin therapy alone, norelstosterone, or medroxyprogesterone acetate or micronized progesterone can be tried. Summary: in endometriosis, functioning endometrial cells are implanted in the pelvis outside the uterine cavity. Symptoms depend on location of the implant. The classic triad of symptoms like dyspareunia, dysmenorrhea, and infertility, but symptoms may also include dysuria, pain during defecation. The severity of symptoms is not related to the disease stage. Diagnosis is by direct visualization and sometimes biopsy, usually via laparoscopy. Treatment include anti-inflammatory drugs, drugs to suppress the ovarian function and endometrial tissue growth, surgical ablation and excision of endometric implant, and if disease is severe and no childbearing is planned, hysterectomy alone or with bilateral salpingoprectomy is advised. These are the references. some picture here, the site of endometriosis, sites here. Okay. Thank you very much for the attendance. Any questions? Can you see? في question from Dr. Munir Khoder. Is endometriosis prevent pregnancy? Yes, it can prevent, but not all cases, because as we see endometriosis, there is minimal, mild, moderate, and severe. And the effect of preventing pregnancy is on the level of the tubal factors and on ovum pickup, and there is mechanical and inflammatory factors. So it can prevent, but meantime, pregnancy can occur in despite there is endometriosis. This abdominal bloating, this is a ovarian factor. Any more question? Okay. Thank you very much. Next speaker, our eminent neonatology consultant and HOD, Saudi German Hospital Riyadh, Dr. Nabil Shahata. Dr. Nabil Shahata will give us a talk or a lecture about birth trauma, which is a very important topic in our field. Dr. Nabil, تفضل.
السلام عليكم. شكرا دكتور لطفي, and thank you for organizing committee for inviting me. And I want to congratulate you all for this very successful meeting. بارك الله فيكم إن شاء الله.
Thank you very much.
Yeah, I can share my screen.
You can share. تفضل.
كده تمام؟
تمام. تفضل.
Okay. Just a minute. Assalamu alaikum. Our talk today will be about birth injuries. We are all concerned with the outcome of the mother and child, and we are completing each other, the neonatology team and the obstetric team. So I just want to highlight some birth injuries or birth trauma which can be happen during the delivery. Definition: the term birth injury is used to denote avoidable and unavoidable mechanical, hypoxic, and ischemic injury affecting the infant during his delivery. Birth injuries may result from inappropriate, deficient medical skill or attention. They may occur despite skill and competent obstetric care. The predisposing factors: fetal macrosomia, prematurity, phallopelvic disproportion, dystocia, prolonged labor, and breech presentation. The incidence has been estimated to be 2 to 7 per 1,000 live pairs, and 5 to 800,000 infants die of birth trauma, and about 25 per 100,000 die of anoxic injuries. Such injuries represent 2 to 3% of infant deaths. We'll start to take a journey for the birth trauma in all areas of the body. We'll start with cranial injuries. The most common is semen ecchymosis official of the facial or scalp soft tissue may be seen after forceps or vacuum assisted deliveries. The location depends on the area of application of the forceps. They are all common. All are probably secondary to sudden increase of intrathoracic pressure during the passage of the chest through the birth canal. Parents should be assured that they are temporary and the result of normal hazards of delivery. I just wanted to stress here on to be honest and speak to the family, clarify everything once it happened. Otherwise, it will be, after this will be a big problem and we all will suffer. First, we'll speak about molding. Molding of the head and overriding of the parietal bones are frequently associated with caput saxtenium and become more evident after the caput has receded and disappear during the first week of life. Rarely, a hemorrhagic caput may result in shock and require blood transfusion. Caput saxtenium is a diffuse, sometimes ecchymotic edematous swelling of the soft tissues of the scalp involving the portion of presenting part during the vertex delivery. It may extend across the midline and across the suture lines. The edema disappears within the first few days of life. This is one of the pictures that can be seen, especially in obstructed labor or prolonged labor. As you see, a big caput, and as we told that the caput is can cross the midline and the suture lines. The swelling and discoloration and distortion of the face are seen in face presentation. No specific treatment is needed, but if there are extensive ecchymosis, phototherapy for hyperbilirubinemia may be indicated. The second one is cephal hematoma. It is a subperiosteal hematoma, most commonly lies over one parietal bone. It may result from difficult vacuum or forceps extraction. As we see the picture here, it is limited to one bone that is not crossing the midline or the suture line because it is subperiosteal. Management is usually resolves spontaneously, but it will take longer time. Vitamin K 1 gram IM, 1 milligram IM is given. Here's some of the pictures. And this diagram can show us where is the birth injury or the caput saxtenium. As you see, it is under the skin, it's just edema. And cephal hematoma is subperiosteal, localized. The caput is diffuse. And there is another subgaleal hematoma, which we are seeing it frequently these days. And there is epidural hematoma, it is inside under the bone. Here how the injury will happen when you will apply the vacuum. We will see that it is on the presenting part, and with excessive vacuum can cause this cephal hematoma. But it is a subperiosteal hemorrhage, so it's always limited to the surface of the cranial bone. There is no discoloration of the overlying scalp, and swelling is usually not visible until several hours after birth. This is important because sometimes when we'll say that there is a cephal hematoma, they will say, no, we saw the baby when the baby delivered and there was nothing, because it is happening after some hours, as the subperiosteal bleeding is a slow process. An underlying skull fracture, usually linear fracture and not the best, is occasionally associated with cephal hematoma. So you may need to do a CT. Most cephal hematomas are resolved within 2 to 3 to 2 weeks to 3 months. It can stay up to 3 months. Depending on their size, they may begin to calcify by the end of the 2nd week. A sensation of central depression suggesting but not indicative of an underlying fracture or bone defect. Hematomas require no treatment, although phototherapy may be necessary to treat the neonatal hyperkalemia if it is severe. Here you can see the ping pong ball fracture, the best fracture, one of the under one of the hematomas is the X-ray. Incision and drainage are contraindicated. In spite of this, some centers are doing this under strict sterile conditions. We are not doing it because of the risk of introducing infection in benign condition. A massive cephalic hematoma may rarely result in blood loss severe enough to require transfusion. It may also be associated with a skull fracture, coagulopathy, and intracranial hemorrhage. We'll go now to the intracranial and intraventricular hemorrhage. As we see here, there is epidural hematoma and subdural hematoma. And there is subarachnoid, often asymptomatic. It can result in apnea, irritability, and seizures. CSF will be bloody, and diagnosis can be done by CT. Intracerebral can present with signs of brainstem compression, or intraventricular, mostly premature infant, less likely caused by intrapartum factors. The risk of post-hemorrhagic hydrocephalus is present. As you see here, the ventricles is full of blood, and there is many degrees, 1st degree, 2nd degree, or grades, and 3rd and 4th. The 3rd and 4th have all the time bad prognosis. The 1st and 2nd, they have good prognosis and can resolve without any sequelae or any complications. It causes sudden compression and decompression of the head, as in breech and percepted labor, marked compression by forceps or cephalopelvic disproportion or fractured skull. Predisposing factors, prematurity due to physiological hypophosphatemia with fragile blood vessels and liability to trauma. Asphyxia due to anoxia of the vascular wall and blood diseases. If it is subdural, results from damage of the superficial vein, where the vein of Gyne and inferior sagittal sinus combine to form the straight sinus. Subarachnoid, the vein of Gyne is damaged due to tear in the dura at the junction of the phallic cerebri and tentorium cerebelli. Intraventricular, inside the brain ventricles, and intracerebral, inside the brain tissue or brain matter. The 1st and 2nd is usually due to birth trauma. The 3rd and 4th, the fetus is usually a premature exposed to hypoxia